So very good afternoon, everyone. So I'll keep it a little bit more practical and brief. So I would like you to interact. So there are a lot of EEGs. I would like you to answer. Slide, please. So we'll briefly look at the focal EEG abnormalities. So as you already heard in the morning, many of things will be repeated in this talk. The focal EEG abnormalities can be epileptiform abnormalities, non-specific abnormalities. So these are two broad categories. So focal EEG abnormalities can be epileptiform, non-specific. So what do you call it as epileptiform? So there are different concepts. One concept says distinct waves or complexes which are very much distinguishable from the background activity with a sharp configuration. American Clinical Neurophysiological Society defines a waveform that is characterized by an amplitude of at least 2.5 times that of underlying background activity with a duration of either less than 70 or 70 to 200, okay? Depending on that whether it is called spikes or sharp waves. So basically the interictal epileptiform discharges are electrophysiological signature of an epileptogenic brain. Epileptic cortex is characterized by paroxysmal electrical discharges. Analysis of these interictal discharges typically manifests as spike wave complexes and plays a crucial role in diagnosing and treating epilepsy. So basically, the spikes or interictal epileptiform discharges are biomarker for epilepsy. So what are the characteristics? This again already was mentioned in the previous talks. So for you to call any transient as epileptiform, it has to conform to the following criteria. It has to be a transient, paroxysmal, suddenly appearing, stands out from the background activity. We already told at least 2.5 times it goes, most of the times, and disturbs the ongoing background activity. Usually it has a slow wave after going, so that disturbs the background activity and has a physiological field. So amplitude typically is more than 50 microvolt, but that can be variable, and that is not usually a criteria. So even though we describe all these, you should not go by only one single criteria. Okay, so we see the whole thing, multiple different things. You should not say, for example, if it is not standing out from background, you should not say, okay, this is not standing out from background, because there are some low amplitude. I will show you some examples of low amplitude activity also. Most of the time these are high amplitude activity, but amplitude alone does not decide anything. So already we described this. So this is less than 70 milliseconds from this point to this point. Okay. So this is called spike when it is less than 70 milliseconds. When it is more than 70, less than 200, then it is called sharp wave, sharp slow wave. When it is more than 200, then it is called slow wave. So epileptiform activity can be a spike, can be a short wave, can be a slow wave also. All right. So some people call all of these as spike without conforming to the morphology. That is okay. There are two schools of thought. A pure EEG person will say you have to describe the morphology correctly. A spike is a spike, a sharp wave is a sharp wave. Okay? But some other people say, okay, for a medical treatment doesn't make any difference. You are not going to pinpoint pre-surgical evaluation, then for medical treatment, it's okay. If you say it is epileptiform activity, it is still fine. Okay? So all these different morphology can be there for epileptiform activity: a single spike, a spike wave complex, polyspike wave complex, periodic polyspikes, a sequential sharp wave activity, or broad sharp waves. All these are different morphologies that you can get for a focal epileptiform abnormality. So the polarity rules already we know. So anything which is lead 1 negative is up. So just remember this mnemonic: lead 1 negative up, line up. Lead 1 negative up, line up. Only remember this, it will not be confusing to you, because for some of the beginners it is very confusing how to remember this polarity rule. Okay, so lead 1 negative up. Okay, so anyone volunteer? Anyone volunteer? Yes. So what is the polarity and localization of this? Yes, madam. What is the polarity and localization of this? We discussed this a lot since morning.
It is going down.
Yep.
So it is going down, it is positive.
Okay. Other doctor? Yes.
There is a downward deflection in the P4O2 leads which indicates that P4 is more negative as compared to O2. No, O2 is more negative as compared to P4. We are going from relatively positive to a relative negative, so we are going down.
So anyone else? Yes.
And
yes, the doctor, please.
Sir, in P4O2, the wave is going down, sir,
Yes.
which means P4 is more positive than O2.
Okay. Yeah. So, and what is this phenomenon called? End of chain.
End of
phenomenon.
chain.
That means why you are concentrated in the P4. End of chain means
Yes, sir.
it is the last electrode in the chain. So that means where
There
is
won't
it,
be-
where is this activity? In this activity is in P4 or O2?
O2.
This activity is in O2. So you have to say in relation to O2 what it is. Right?
Yes, sir.
So end of chain phenomena and O2 is the maximal activity. O2 is the second input. What in the second input will cause downward deflection? That is the question. See, now you
Negative,
come to
sir.
this.
So,
Yeah.
O2
You come to
is
this rule.
Negative.
Lead to negative is down.
Down.
Now, is it clear to everyone? I am spending some time here because this is often confused. This is very difficult for some of you. Is it okay? Anyone still doesn't understand this? See, when you have only the fourth channel showing any activity, not the three other channels, this is end of chain phenomena. That means O2 is the problem. The problem is in O2, not P4. Okay? Which in the second lead will cause downward deflection. The negative in second lead will cause downward deflection. So this is O2 negative spike. So rhythmic focal right occipital spike wave discharges. Okay, that's how we will describe this. So in a bipolar montage, negative activity, when it is in the second input, it will go down. So this is a very characteristic appearance of occipital spikes. Okay, so in case of post, you will have an opposite. In post, in the bipolar montage, you will have opposite deflection, right? And this is the same page in referential montage. Goes up. O2 is now lead 1. That's why it is going up. The reference, average reference is the lead 2. O2 is in lead 1. That's why it is up. So this is referential montage. This is bipolar montage. This is very characteristic appearance of occipital spike. Don't ever forget this. Okay? I'm going to show you more examples. This is another page from the same patient. Again, another important aspect to look at here is, are they monomorphic or are they different in morphology? See, when we say monomorphic, we don't say 100% monomorphic. Nothing in EEG happens like that. Okay? If it is 80%, 90% looks similar, then it is called monomorphic. Okay, now I've given you a clue. This is monomorphic, polymorphic. So, see, this is downward and then wave, then a slow wave, downward, upward, slow wave, downward, upward, slow wave, downward, upward, slow wave, correct? So if you put each on top of one another, 80% they conform to the same morphology. So this is monomorphic. This is very important aspect to remember. This is high amplitude, monomorphic, otherwise called stereotyped focal spike wave right occipital discharges. Okay? Why I am emphasizing that point? This is a very characteristic appearance of benign occipital epilepsy. If you have EEG like this, this is pathognomonic of benign occipital epilepsy. Okay? Any doubts? So the same page in, and this is another patient. Now many of you can say whether it's a monomorphic or polymorphic. This is monomorphic. So this is the definition of monomorphic, right? And this is a bipolar montage, and this is bilateral discharges, O1, O2 both, and downgoing. So what is the polarity? Occipital, negative. Bipolar montage, occipital, negative, lead 2, right? So this is again benign occipital epilepsy. Very high amplitude, very monomorphic, focal, stereotyped spikes. Same page I have shown in the referential montage. Another page. Okay, so this is again nearly monomorphic. There are some discharges which show some different phases, but most of these are monomorphic. Okay. So now that in these kind of patients, there is no focal slowing. In benign occipital epilepsy, the spikes will be there. Otherwise, the background activity will be normal. No focal slowing in the occipital. Compared to that, this patient, look at this focal O1 delta slowing, then sharp wave, spike, polyspike, a spike wave, and another polyspike wave. Okay, all these are there in the same page. Slowing, spikes, sharp wave, polyspike. Okay, so this is something different. This is not a patient with benign occipital epilepsy. And look at this page here. So this is spike, fast spike, focal fast spike O1. This is polyspike. This is single spike wave. This is a polyspike, spike wave, and there are some different spikes and focal fast activity and polyspikes. All these are the same page. So this is a typical polyspike, this is a typical polyspike. So this is what is called polymorphic. Compare that monomorphic, this is polymorphic. The discharges are different morphology, same page, same EEG, right? So another example, same patient, look at the polyspike, spike wave, some of them are short wave also. Look at this short wave. This is a very typical polyspike. So each discharge is slightly different, not one on the same. So this is polyspike and polymorphic discharges. So the importance is when you have a very focal stereotyped monomorphic discharges in children with a clinical suspicion of benign occipital epilepsy, that is pathognomonic EEG. When you have these polyspikes, pleomorphic, different morphology of the spikes, then this indicates symptomatic occipital epilepsy. That's why we need to differentiate this. Okay? So in a benign occipital epilepsy, the prognosis is different, the treatment is different, and we may not even do MRI for the patient because we know MRI will be mostly normal. But in a symptomatic occipital epilepsy, these are different prognosis and different substrates. We need MRI. Mostly they have gliosis or some focal lesions there. Okay? So this is a differentiation, and the EEG gives you a valuable clue there. Coming to other discharges, so the transients can be single transients, or the transient can be in a rhythmic run like this. So in this patient, what you are seeing, for 1, 2, 3, 4, 5 seconds, there is a rhythmic run of discharges, fast spikes. Okay? So these are what are called brief potentially ictal rhythmic discharges, or BIRD. This is called BIRD. So this is also focal epileptiform abnormality. Okay? So this is basically a continuum between interictal and ictal. So I'm not going to go into those things, but this also is considered epileptiform. So another example, BIRD. And what you can have, see this paroxysmal fast activity, sudden onset, sudden offset, then it goes off, then another paroxysmal fast activity, another paroxysmal. So this is another epileptiform pattern, focal paroxysmal fast activity, again in the occipital region. So all these can be a focal epileptiform patterns, need not be only spike. Okay, it can be in a run, it can be in a rhythmic discharge, it can be BIRD, it can be focal PFA. Yeah? No. So this is the interictal slowing. Okay, this is not evolution, this is interictal slowing. So this focal PFA, you can call it as BIRD also. So these BIRD and focal PFA are slightly interchangeable and similar concept. So if you call this as a BIRD, fine. If you call this as a focal PFA, fine. But this is focal epileptiform pattern. That's a more important thing. Okay, now we completed that. Now we go into the next epilepsy syndrome. Okay, so this is a focal rhythmic discharges, again monomorphic stereotype discharges. But where is it maximum? Right central and temporal. Okay, right central and temporal maximum, and there are multiple discharges, rhythmic, repetitive. Okay, so what are these? What is epilepsy syndrome? Yeah, so this is what we used to call benign Rolandic epilepsy or self-limited epilepsy with the centrotemporal spikes. Okay, selects. So in this also the same. This is also benign Rolandic epilepsy. The one characteristic you have to understand is this is a bipolar montage. What I have done, I have removed the right-sided leads. I have shown only the left-sided leads for a purpose. Okay, so I have shown here left parasagittal, left temporal, and midline. Okay. So this has a very complex field. Okay. So what do you see? There is a phase reversal here in P3. Okay. There is a phase reversal in T3. Are you able to appreciate? T3 is easily appreciable. The P3 is slightly difficult because it's a higher amplitude and overlapping. Okay. So P3, T3, phase reversal. Okay. So what is a more interesting phenomena here is what is happening here in the F3. Yeah. So what is happening in the F3? What is this called? Yeah, tangential dipole, but what is this called?
Phase out. Phasing out.
Yeah, this is positive phase reversal. This is called double phase reversal. If I put you this picture, for some of you it will be more clearer. See here, you have a upward phase in FP1, and here you have a downward phase. This is called positive phase reversal. How you have a negative phase reversal, this is a positive phase reversal. The next electrode, in P3, you have a negative phase reversal. Okay? So in the positive phase reversal, negative phase reversal, both are seen on the surface. That is why it is a tangential dipole. And this is called double phase reversal in bipolar montage. So this is a characteristic of centrotemporal spike. It's a characteristic of tangential dipole. So you have to recognize this EEG as such. That's a very, very, very important. So this is just to show you different radial component and tangential component. Tangential is very parallel, horizontal. Radial is all other. In the radial dipole, you won't see the positive phase on the surface because positive phase is in the base of skull. Okay, you don't record the positive phase when it is a radial dipole. When it is a tangential horizontal dipole, you record positive phase also in the surface. And the same examples, this is another one, okay. So here also you can see positive phase reversal and negative phase reversal. So for all of you, especially adult neurologists, if you have this typical appearance of this kind of EEG, where you have a phase reversal there in C4, T4 or C3, T3, and there are multiple discharges during sleep. So first differential diagnosis should be BRE, benign rhodontic epilepsy. If the patient is that age group, middle-aged child, and the patient has a nocturnal rhodontic seizure, so this is a characteristic EEG, and this is the most common EEG abnormality you come across in a school-going child, in a middle-aged child. So this should not be reported as temporal lobe epilepsy or central epilepsy, all that, okay? So this should be identified. Another example, again, this is awake EEG. Awake EEG itself is so frequent, okay? So all these benign epilepsies have a marked sleep activation. Same patient, while awake, very frequent left centrotemporal spikes. When you do sleep EEG, this is called ESES, electrographic status epilepticus in slow wave sleep. So marked activation is the characteristic of many childhood epilepsies, including childhood benign focal epilepsies. So what we learned so far, many epilepsies in childhood show sleep activation. Awake EEG may be even normal. Benign rhodontic epilepsy, nocturnal seizure, patient comes, you do awake EEG, EEG will be normal many times. So you have to do sleep EEG. Inclusion of sleep EEG increases the diagnostic yield, and EEG should always include sleep in children, okay? So sleep EEG recording, so far we have covered careful EEG analysis can classify epilepsy into focal and generalized. I showed you all the examples for focal. Can clinch the diagnosis of epilepsy syndrome. Just by looking at one page, I told this is benign occipital epilepsy. This is benign rhodontic epilepsy. So epilepsy diagnosis, syndrome diagnosis is possible with the careful analysis of EEG. Can identify underlying structural etiology. I told you that focal polyspike is indicative of pleomorphic discharges are indicative of structural epilepsy. Focal polyspikes can be indicative of repetitive bursts, can be indicative of FCD, focal substrate also. When it is a multifocal polyspikes, it is indicative of HIE sequelae. Okay, focal polyspike is more FCD. Multifocal polyspike is, there is a paper on Annals of Child Neurology. They differentiated focal polyspike, multifocal polyspike. So it can aid in prognostication. Say for example, a patient comes to you at 2 a.m., child had a eye deviation, repeated vomiting. You suspect 3-year-old child normal completely. You suspect it is a Panay-Topolo syndrome, benign occipital epilepsy, and that is the first seizure. You may not start the treatment, and that may be the only seizure the child ever has. So that is a prognostication, can be. So if you analyze carefully all these EEG, all these can be deducted from that. So is the presence of intraictal epileptiform discharges always diagnostic of epilepsy? Yes, no. How many of you yes? Come on, hundreds of you, at least few will be yes. Yes, don't disappoint me. Is presence of IEDs not diagnostic of epilepsy? Okay. Why? Why?
BRE, this trait can be there, like many of us will have this centrotemporal.
Fine. Many times correct diagnosis made in the conference halls than in the clinics. Right. So, yes, as you said, the EEG traits much more common. In these are very old studies, but up to 6% of children, 6% of children, they can show centrotemporal spikes as an incidental finding. They never had seizures, they will never have seizures in the future. Up to 6%. Okay, so that's a huge number. So 1 to 6% of patients can have especially centrotemporal spikes or central spikes as an incidental finding on EEG. So just looking at spikes or centrotemporal spikes, don't diagnose any patient with epilepsy. He has to have a clinical seizure for you to have epilepsy. Okay, going forward, now I've completed the childhood focal epilepsies. This is a very classical example of rhythmic temporal intermittent delta activity. Okay, so this is what we call TIRDA. And there are frontal intermittent rhythmic delta, occipital intermittent rhythmic delta. Okay, frontal intermittent rhythmic delta can be a normal variant, especially in young children, young patients, right? But TIRDA is always considered epileptiform. TIRDA is always considered epileptiform. Occipital intermittent rhythmic delta is in between. TIRDA is always epileptiform. FIRDA can be mostly normal. Occipital intermittent rhythmic delta is in between. Depending on the situation, it can be normal also. It can indicate epilepsy also. So this is the rhythmic delta activity. So what do you see here? Anyone? Anything? I'm pointing out where you have to see. So as against this rhythmic delta activity, here it is polymorphic focal slowing. So right temporal polymorphic delta slowing. Okay. So rhythmic delta, polymorphic delta, both are possible in focal temporal lobe epilepsies. Okay. Look at this. This is not that rhythmic. It's a different morphology, polymorphic. And what do you see here? What is the localization of this? So there is a focal transient. Everyone agrees? Focal transient. Okay. What is the polarity? So there is a flat line in between. There is a phase reversal across this flat line. That means what? Phase cancellation. That means F7T1 are equipotential. That's why it's a flat line. So this is a focal left temporal, anterior temporal spike wave discharges, okay, which shows phase cancellation. F7T1 is equal. So let us confirm this in a referential montage. Look at this F7T3, okay. So T1 they have not shown in this. So F7T1 will be equal. T3 is little bit. So this is a physiological field. You can see it is running off. The voltage is running off. Okay. So this is what is called physiological field. So this is very characteristic of TIRDA, and this is very characteristic of mesial temporal lobe epilepsy. Okay. Same patient has a TIRDA, same patient has the focal temporal spike like this. It's a very characteristic of mesial temporal lobe epilepsy. Another example, mesial temporal lobe spikes. There can be sharp wave, there can be spike. Same patient can show different morphology. So another page from the same patient. Okay, this is another patient. So right side, very focal temporal spike wave. Okay, again F8T2 is same phase cancellation, equipotential. So this is in the referential montage, same patient. Okay, what do you see here? What are these? Focal sharp wave activity in T1. Okay, left anterior temporal focal sharp wave activity. So all these are different flavors I'm showing you for temporal lobe epilepsy, because this is one of the most common epilepsy most of the adult neurologists you will be coming across. So another page from the same patient, focal spike and sharp wave in the T1. Okay, what do you see here? Focal spike wave, okay, rhythmic focal spike wave, T6. So this is temporal neocortical epilepsy. Previously we showed T1 or T2 maximum, that is mesial temporal lobe epilepsy. Here this is a posterior temporal, T6. So this is a temporal neocortical epilepsy. Okay. And what do you see here? So this is sleep EEG. What is here? So there is a delta activity, rhythmic focal delta activity. Okay, frontal and frontotemporal. Okay. Along with that, same region is showing spike wave also, correct? Same region showing focal slowing, focal spike wave. So that means, is it a benign epilepsy or symptomatic epilepsy? This is a likely symptomatic epilepsy. Possibly there may be structural etiology. So same patient, persistent focal slowing. You can see persistent focal slowing, okay? And rhythmic spikes in that same region. So there is a likely possible right frontal gliosis or some structural etiology will be there. Same, during sleep you can see a little bit more polyspikes, more focal fast activity. All right. And on the other hand, this patient shows bifrontal, spike wave bifrontal. So FP1, FP2 predominant. So usually any activity in the frontal lobe, usually it will be bifrontal. Very rarely you will see only unifrontal. So most of the time the rule is bifrontal. So this is a bifrontal slow spike wave activity. So another page, same patient, very rhythmic, very frequent bifrontal focal epileptiform activity. Another page, same patient, you can see FZ, FP1, FP2, all that showing bifrontal activity. So another different patient, again you can see bifrontal spikes as well as polyspikes. So here you can see polyspikes. Okay. So this is a bifrontal activity, sometimes right side, sometimes left side, sometimes together. So this is a very characteristic appearance of a frontal focal epilepsy. Frontal focal epilepsy. Another page, same patient. So you can see independent right side, 1 minute. Independent right side, independent left side. Okay. So sometimes it occurs together. So this is very interesting patient. It's a midline rhythmic frontal. So some of the EEG machines, they by default don't have FZ, CZ. If you don't have a midline electrodes in this patient, you will miss the focal epileptiform activity altogether because that is the only electrode that is showing this activity. So when you have a set up your EEG machine, you have to go to your EEG technician and engineer to get included FZ, CZ and PZ because a huge amount of activity abnormality that you can miss if you don't have the midline electrode. So this is a different patient, has a midline spike. In the whole morning you saw midline sharp waves, vertex sharp transients, right? But this is spike wave. This is rhythmic spike wave. So it's a rare, CZ midline spike is less common, rare. So that's why we said any activity, sharp activity, focally you see in CZ, first you should think of vertex sharp transients. But morphology, you should always be very careful. This is a spike wave morphology. This is a midline central spikes. Another page from the same patient, midline central spikes. And this, you can see the difference between this and vertex. The main difference is vertex sharp transient is a single sharp wave. It doesn't have a sharp and slow wave. Here, the focal epileptiform discharge in the midline, they always have a sharp and following after going slow wave. Okay, this is the main difference. The morphology is different. Sharp transient, only sharp wave. There is no slow wave. Here, sharp and slow wave. So that's the main difference. So this is another page, same patient. You can look at the morphology, which is very much epileptiform. And the one important message here is many patients with cerebral palsy, many patients with developmental delay, they can show central spikes, but they may not have a seizure at all. Okay. So this is another pattern where you have a low association with seizures. So say for example, you have a rhythmic spike wave, JME pattern or IgE pattern on EEG, the seizure recurrence rate is more than 80%. If you have only central spikes, especially in a child with a cerebral palsy who never had a seizure, the likely recurrence rate for that child will be less than 5%. Okay? So this is what is the recurrence rate depending on the EEG pattern. So this is a central spike, another patient. And see this one, very, very small amplitude. So this is what I meant. Amplitude alone does not decide anything. So just because it is a small amplitude, you should not say, okay, this is not an epileptiform abnormality. This is a very small amplitude, low amplitude activity. This is the classical example of central spikes in a patient with cerebral palsy. These are very small amplitude sometimes. So you have to keep looking for it. So with that, I'll conclude. So if there are any doubts, we can clarify during the demo session.